It's really an honor for me to be here, and this topic I think is very important for me. I have an interesting job in that I teach in the medical school the first 2 years in the classroom, big lectures, but I also take care of patients. Most of what I do actually is take care of patients at Harborview. So I take care of people with kidney disease. And so I have the opportunity to teach medical students, interns, residents, and fellows. Those are people who are done with their residency who want to specialize in kidney disease. And I struggle with the professionalism question every day, how best to teach professionalism to the trainees, because the way I learned was from the people above me. I'm fortunate today to introduce two people that are involved in the teaching of professionalism in a way that I didn't get to experience in my medical school. Ray Maestas is an associate professor and a faculty member in the UW School of Medicine in the colleges system. As Terry mentioned earlier, there are 5 colleges that the medical school has been divided up into, and Ray is in charge of the Denali College. She's also the associate chair for the Introduction to Clinical Medicine course. I first met her when she was at Providence, and I was at Providence a while ago in my career, and I was always drawn to Ray because she's drawn to things that I'm also drawn to, specifically working with the underserved and other things that are listed. She received her MD from the University of Washington School of Medicine and completed a residency in family medicine at Providence. And she's received a bunch of teaching awards. And in particular, I was struck by the fact that she was recognized on the floor of the U.S. House of Representatives as a nominee for the Local Legends Project that honors women. So that's Ray. Jenny Strauch is manager in the Clinical Skills Laboratories, assessment manager. She works as part of the Health Sciences Academic Services and Facilities Department. Much of her work involves working with faculty to develop scripts and then training the standardized patients to portray roles consistently. That's something that I didn't experience in medical school, and I think it's a huge thing for our trainees here at the University of Washington. She also works with physician assistants, nurse practitioners, the pharmacy, and social work training programs. She earned her bachelor's degree in biochemistry from Evergreen State College in Olympia and her master's degree in education from Western Washington University in Bellingham. She was a founding board member for the Association for Standardized Patient Educators, ASPE, and the Professional Organization for the Field of Standardized Patient Education. She was elected the ASPE president for 2008 to 2009. Jenny Strauch, thank you.
I'd like to start out tonight with a brief story. This is a story about a student of mine who actually taught me and my small group of students about professionalism one day. During one of my clinical teaching mornings at the hospital, one of my students was assigned to interview an elderly gentleman who we soon discovered had a variety of problems going on, or things going on that was going to make this particular interview very challenging. His speech was hard to understand because he had had a stroke, okay, so he had aphasia, and his dentures were lost. When he got admitted, his dentures didn't arrive with him. He had hearing loss, and he had an accent. I think many of my students would gladly have taken an offer to interview a different patient. And the reason is because the students are evaluated on how much information they can gather from this interview under a certain period of time and how well they can organize it into this very neatly written write-up, and we grade them on it. So most of my students would say, yes, please, give me someone who I can interview and look good. This student turned to me and he said, he declined my offer. Quite politely. And he gently reminded me that it was important for him to learn to care for all patients, regardless of the issues at hand, and he was willing to give it his best effort. When he presented the patient's story to the other students, it was impressive how much detail he had gathered and the wonderful story that he was able to provide. I have to say I was really caught in my tracks, because that was a moment in time where the student taught me and taught us a lesson about professionalism. I think this scenario speaks to the kind of professionalism we're going to be defining and discussing tonight. And I'd like to start out by saying that a lot of what I'm going to say, Dr. Pinsky has done a marvelous job of doing. But in the spirit of a true educational forum, first you tell your students what you're going to teach them, then you teach them what you're going to teach them, and then you tell them what you've taught them. So I think that's going to work, okay? So my goals for tonight are to review a definition of professionalism, which is, I think you've already begun to get oriented to, why we should be teaching this in medical school, and the methods, and we'll go over some of the methods used for teaching professionalism, and we're going to have fun. We're going to demonstrate one method that we use to simulate a patient encounter with standardized patients tonight. So, professionalism. This is one definition that has been put forward, and I think we like it here at the UW, and see what you think about this. Professionalism is demonstrated through a foundation of clinical competence, communication skills, and ethical and legal understanding, upon which is built the aspiration to and the wise application of the principles of professionalism: excellence, humanism, accountability, and altruism. You might ask, what does this mean? Well, we all want a physician who is knowledgeable and competent, and that is absolutely essential. That's the foundation. But that's not enough. We want a physician whom we can trust. Someone who demonstrates their ongoing excellence, their humility, on whom we can depend on, and who have our best interests in mind and are willing to provide us with the best care possible. These aspirational principles of professionalism, excellence, humanism, accountability, and altruism, are the additional necessary elements that keep us focused on what's really important here: the patient. It's a critical aspect of clinical training, and at the UW School of Medicine, we've expanded those virtues of these 4 pillars that you saw into 7 key values. We believe that the patient's best interests are kept in central focus when the physician aspires to uphold these important values or behaviors that engenders the patient's trust. In excellence in scholarship, this is the physician who strives for excellence and appropriately applies his or her medical knowledge and skills. This physician embraces the concept of lifelong learning, which you've heard about, continuous skill and knowledge improvement through collaboration with colleagues. This physician leads by promoting a high standard of medical quality and integrity through example and willingness to share knowledge and skills with others. A caring and compassionate physician communicates understanding of another's perspectives and feelings, feels the suffering or distress of another, and has a desire to relieve it. He or she maintains professional boundaries with patients while nurturing a level of relationship necessary for optimal care. A respectful physician shows regard for another person and their values and beliefs with esteem, deference, and dignity. This person ensures autonomy and respects patients' individual choices. A responsible and accountable physician takes ownership for their patient's care and follows through on that commitment all the way. A physician with honor and integrity is forthright, fair, honest, and truthful, keeps his word, and meets his commitments. He knows the limits of his knowledge and is honest about it and consults others readily in behalf of his patients. This physician faces his or her mistakes honestly and learns from them. An altruistic physician carries out actions aimed at improving the welfare of another, especially someone in need, even when his or her values are in conflict with a patient. This physician recognizes when to place the patient's need in front of their own and advocates in behalf of patients who experience barriers to needed medical care and services. So why should we be teaching this in medical school? You know, recently a first-year medical student shared the following, which is really quite representative of the first-year medical incoming student. This student said, "My intention is to serve patients with genuine concern and compassion, and to share my knowledge and skill to the best of my ability. I hope to accompany my patients in a healing relationship that even when the medicine is no longer effective, I hope to provide comfort and care. I hope to be worthy of being there for my patients even as death approaches. And I hope I can carry out this privileged responsibility with joy and humility to all who come under my care." Well, if all our students are entering with this kind of personal oath and commitment and promise, what more do we need to teach? It seems like it's all there, right? We know that the rigorous journey through medical training challenges many of our students and challenges the values that they come into medical school. In some situations, a student may experience two or more values in conflict, and it doesn't take very long in this career, in this path, before they're confronted with, how do I balance my personal needs, the needs of my family, my loved ones, and my interests, my commitment, my want to give it all to this career? Students need opportunities to reflect, deliberate, and anticipate how they might make decisions and act in certain situations that will present themselves throughout their training and careers. You know, we also know, unfortunately, quite regrettably, that doctors who get in trouble with medical boards later, years later in practice, are more likely to have shown some unprofessional behaviors early in medical school. Well, that gives us, we think, an opportunity for early recognition and remediation. Patients tell us that they prefer doctors who dress professionally and that they're more likely to divulge their social, sexual, and psychological worries to doctors who dress professionally. This is really an issue of respect and trust, which, if it's not attended to, could compromise the doctor-patient relationship. For medical students, for many medical students, learning or incorporating professionalism into their evolving identity as a healthcare professional is a developmental process, and we believe that our curriculum needs to address that developmental process in a very respectful manner. So, for example, for the value of respect, that's one of the 7 values that I listed earlier. During the student's preclinical stage, during the time that they're spending time in the classroom, in the first 2 years of medical school, we want to see behaviors manifested that promote a learning environment for classmates by respectfully providing feedback to faculty and ways to improve the educational process for all students, current and future. During their early clinical training, respect is manifest by keeping patient confidentiality, respecting patient's dignity by addressing the patient formally, Mr., Ms., Mrs., by attending to the patient's physical modesty, and by addressing in a respectful manner. During later clinical training, in clerkships, when students have more in-depth relationship with patients and members of the healthcare team, respect is manifest by demonstrating respect for patient autonomy, patients' choices and idiosyncrasies, and treating all patients and their families with respect, working collaboratively with and speaking respectfully of all members of the healthcare team. We call these benchmarks, or behavioral guides, if you will, and we've developed these benchmarks that are appropriate for each level of training, as you see here, for each of the virtues listed on this next slide, which is a repeat of the slide you've seen before. So I'd now like to turn my attention to the strategies for teaching professionalism. Understanding the connection between professional values and behaviors which manifest these values takes time, exposure to the concepts through a variety of settings, discussion, practice, reflection, more practice, and ongoing reflection. You've also heard about the colleges. With the implementation of the colleges, the college mentoring system, whereby each student is assigned a mentor at matriculation, the teaching of clinical skills and professionalism has been greatly enhanced for students during the early years of their medical education. This mentoring system has provided more opportunities for one-on-one discussion, small group discussions on clinical stories or other issues of professionalism, role modeling at the bedside, and observing student-patient interactions provides an opportunity for timely feedback and the beginning of the self-reflective process. Students continue to get excellent teaching and role modeling in the clinical phase of their training in third and fourth year from clinical faculty throughout the WWAMI region. Simulated patient encounters is another effective way for students to get early experience trying out new skills in a safe, less anxiety-provoking environment, and we'll hear about this in a moment. Now, I've sort of glossed over lectures because our students tell us that lectures are boring. And so here you are listening to a lecture from me, and I apologize for boring you, but we try to limit our discussions or our teaching on professionalism to very few lectures. We try to keep them outside of lectures. We do respond to the feedback that the students give us on how to best teach them these topics. So let's talk a little bit about the trust-based doctor-patient relationship. Trust is earned by adhering to the values that consistently promote integrity, respect, and compassion, and puts the interests of the patient first. We're going to see a role play that will call on the student to consider these virtues or behaviors, and we'll get a chance to get your input as well. Before doing that, I want to reintroduce to you Jenny Strock, the director of the Standardized Patient Program at our medical school, and she'll introduce the role play and the role of standardized patients in simulated learning environments. Jenny?
Hi, I'm Jenny Strauch, and I just like to repoint out I'm not a physician, but rather I'm a medical educator, and I work in a specialized part of medical education, which is that of medical simulation. And so, in a nutshell, I work with faculty to develop teaching programs and assessments that involve many types of clinical tasks and situations, and one of those, a very large one of those, is that of mock clinical types of encounters using standardized patients. And today we're going to use a standardized patient to demonstrate one of the ways that we teach and assess professionalism. And because people generally have a lot of questions about what are standardized patients, before we move on to the role play, I'd like to take a moment to talk to you about the amazing profession of standardized patient. And who knows, maybe some of you will be very interested in this and might become some of our standardized patients later. First, I like to point out there's always an obligatory academic definition, so I'll whip the one out from the Association of Standardized Patient Educators. A standardized patient, or SP as we often call them, is a layperson trained to portray a patient scenario for the instruction, assessment, or practice of communication and/or examining skills of a healthcare provider. In the health and medical sciences, standardized patients are used to provide a safe and supportive environment conducive for learning or for standardized assessment. So again, what are we really doing with these folks? What are standardized patients, and what makes them different from just maybe bringing in a real patient to work with your students or to bring in actors for, we could bring in actors, sure. But standardized patients are really their own breed, their own developing profession. And I say that because there are a number of people who are doing this almost full-time now in some of the testing centers out for the national board exams. And standardized patients have a number of things that make them special. One is they're programmable. And what I mean by that is if we need all 180 medical students, 180 now, to work through a professionalism scenario, we can write the script, hire the patients, bring them in, train them to represent it accurately, and put all of the students through the same type of situation. We can also train them to be able to rate the student based on their performance in that station. They're also reproducible. And for instance, I'm thinking of one standardized patient who's played a specific role thousands of times over the 10 years that she's worked with our program. So that's one way. So we can always be sure that we have that patient available for students should we need so. Or a really common application of reproducing our standardized patients is to bring in maybe 4 or 5 people and train them all to present the same case in essentially the same identical standardized way. And that's really important, especially when you're doing exams and you need to get everybody through in a short period of time. But some of the things I like about standardized patients is they're really safe. And they're safe not only for the patients, because we're not bringing in people who might be sick to undergo multiple exams by medical students, but they're really safe for the student as well, because it's a safe place to make a mistake, try out some new things, and to actually get feedback from the patient so that they can move on and improve the next time that they're seeing someone. And that's, again, really brings us to instructive. They are not just role players or actors who go in and simulate things and walk out. Standardized patients are trained to be able to assess students and to provide specific feedback about the encounter. So we can train our SPs, and we do, to rate the student's performance on physical exam and the medical interview. But where they really shine is in giving detailed feedback about communication skills, what we call bedside manner, about professionalism, and about some of those really difficult to pinpoint qualities of rapport or empathy. And so whether a student sees a standardized patient as part of a teaching session or part of even a test, an exam, they always learn something, and they're very popular with the students for this reason. And that brings us to sort of an unrecognized part of the standardized patient. By teaching lay people about the real patient histories, and we do use real patient histories that make up our standardized patient scripts, by then teaching them about what comprises a medical history and a physical exam, and then giving them the chance to work with students, to rate the students, to give feedback to the students, and through doing that, to give feedback to the whole medical school. The standardized patient really comes in and represents the voice of the patient. It's often unheard, but having these patients with us at all times is always bringing us back to the patient as the center of our teaching and learning, and to the very reason our profession exists at all. And so with that in mind, I'm very excited to bring you a standardized patient demonstration today.
Hi, Josephine.
Hi,
It's great to see you.
great to see you too.
How are you doing today?
Really well. My wrist feels a lot better, and since today's my last follow-up appointment.
That's terrific. I'm glad that things have improved so quickly. Can I take a look at that?
Yeah.
Are you having any pain at all?
Not really. Seems to be almost back to normal, which makes me glad because I miss playing basketball.
I'm glad too. Keep up the great work. You know, I wanted to tell you that I've really enjoyed our time together here on my clinical rotation. It's been a pleasure working with you.
Well, me too. I really think that you're going to make a great doctor.
Thank you.
Hey, you know that band I was talking about last time we were here, the Scissor Sisters?
Yeah.
They're coming to town in a few weeks.
I know. I really wanted to go. I was so upset when I wasn't able to get tickets. They sold out so quick.
I've got 2 tickets. You could join me. We could go together and we could talk some more about music and sports.
Oh.
Well, we have a situation here. And in medical education, we call this a teachable moment. So our student has some options that you can begin to see that he's beginning to think about what is he going to do. Okay, so here are some of the options that he has. And I think he might need some advice from the audience. So we're going to have you take a vote. And these are the 4 options. First, he said he could say, sure, I'm free that night. I'd love to go. How many of you think that's, yeah, okay, we have a few. Yeah, that's good, all right. Never pass up a free ticket, concert. Okay, so he could really turn to the patient and out of frustration or something. That would be totally inappropriate. How many? No takers on that one. Okay. He could say, give me your phone number and I'll get back to you. And he figures he's going to get out of it some way later on. How many folks would? No. Yeah. Okay. Or he might say, I wish I could do that, but I don't think it would be the right thing for me to do. Oh my goodness. Diplomas? It's like, you guys are excused from the rest of many medical school. Go home. Go be with your families, you've got it. Well, the student has taken your advice and under consideration, and let's see what he's decided to do.
Hey, I've got 2 tickets. Why don't you join me? We can go together and we can talk some more about music and sports.
Oh, well, it sounds fun, and I'd really like to go, but I don't think that's such a great idea.
Really? Why not?
Well, you're a patient here at the medical center. There's a chance that later on in my training I could be involved with your care again sometime. And so if we had a friendship outside of the medical center, I think that it might jeopardize my ability to be objective in that care. And above that, if I'm still around and you're coming into the office and need to disclose some personal information to the other physicians here, I wouldn't want you to feel uncomfortable about that.
Wow. I hadn't really thought of it that way. I guess that probably would be weird. Well, like I said, I've really enjoyed coming here, and I think you're going to make a really great doc someday.
Thank you.
And who knows, maybe if I come back sometime for something, you might be my doctor, and I can tell you how the concert was.
Sounds good.
Great. Stand there. So, first of all, I want to thank our actors today, Amber Wolf from the Standardized Patient Program, and a real medical student, Jonathan Griffin, and also want to let you know that the story I started out with this evening with a medical student who taught us a thing about professionalism was Jonathan Griffin in his 2nd year of medical school. Thank you. Yeah. So, did the student do the right thing? Yeah. That wasn't easy to do. So, in real life, we would probably have discussions around this, but the beauty of standardized patients or discussion is that you can practice and you can discuss the pros and cons and play it out and try these words. Because the first time someone has to say this to a patient, it can feel like you're being rude or you're being hurtful in some way, when in fact you have the patient's best interest in mind. So in discussion with students, we might ask, so what would be the consequences of choosing one of the other options? Was the student compassionate and respectful in his response? Did he have the patient's best interest in mind? And in what setting might it be okay to attend a social event with a patient, if any? I think some of you may be thinking, well, what would be so wrong about that? I mean, some of you in the audience are perhaps friends with physicians or your parents or you've seen these interactions occur, and you go, under what circumstances might those situations be occurring? Consider, for example, a rural setting of a 50-year-old female doctor invited by a fellow church member and a patient of hers to a book reading, or a local high school concert where both their kids attend, or another community event. Would that be inappropriate? Maybe, maybe not. How might this physician balance her role as a physician and as a friend? One situation could place a patient in a vulnerable situation, and another one might not. Scenarios such as these are used to demonstrate that there's often no absolute right or wrong way to behave, but rather that it's important for us to consider the consequences of our actions. And these are the types of questions that lead to exploration and rich discussion on a number of issues. And it's not lecture format. It affords the opportunity to reflect on whether a decision to act in a certain way might have negative consequences for a patient. When does a friendship with a patient become a compromising situation for a patient, for the doctor? How will information learned in the social setting be dealt with in the clinical setting? How will information learned in the clinical setting be dealt with in the social setting? These are things we want our students to engage in thought. And ultimately, the student and the practicing physician in the rural setting will need to follow their own counsel. But we hope that by spending some time thinking about these issues during training, students will find ways to keep the patient's best interests first, maintain their patient's dignity and their own integrity as they factor in the realities of their practice settings. In summary, we think teaching professionalism is important and necessary. The behaviors we hope to see in our students and ourselves reflect the values we hold important in the care of patients who have entrusted us with their care. And specific development benchmarks or behaviors are important and are expected of students as they progress through their training. We can only hold them accountable for things that are within their stage of development. Standardized patients, as you've seen, provide a very effective method for training and giving feedback to students on issues of professionalism. Medical school provides a base and a guide, if you will, on which future education, professional development, and lifelong learning is built. And we hope with all our hearts that our students will develop their own mindful and appropriate moral compasses as they journey through the very many different paths they will take. Using the words of my yoga teacher, if we lead our lives with attention, positive intention, and mindfulness, we become our own true teachers. And I remember that now because she says that at the end of every session. So, and you have to repeat things so that they stick. By now you've wondered why I've chosen this background to my presentation. There's the moral compass. And those are the many paths that our students will journey through. And moral compass is a term that Dr. Mengert has coined for us in the colleges, and so I like to refer back to him. And so you need to follow your own moral compass ultimately. And I want to thank you very much for your attention and your interest in this very important topic. Thank you. I don't know if you want to do comments or questions.
Yeah.
I'm just curious how the college system works in the medical school.
Terry, you want to take that one?
The college system is designed to separate the students into smaller groups because it's a big medical school, 180 students per year. And they are assigned a mentor who is sort of with them throughout their training. So we get to meet them in their first year of medical school, and then we work really closely with them at the bedside of patients in the second year. And then throughout the third and fourth year, we get their grades and we have email communication and periodic get-togethers. It's a way of trying to model clinical skills and professionalism at the bedside. And all of the college faculty members me being the exception, were hired because they're very professional and kind and caring people. So it's nice in a way because so much of medical school in days past lacked that constant continuity with somebody that you could connect with and that who had, like our patients, our medical students, we like to think their best interests in mind. And it's hard. Being medical students is a hard job. And they have self-doubts and they have value issues that come up, and they have times when they want to leave, when they want to walk away. And the rate of depression in medical school runs at as high as 20%. So it's nice to have somebody who has seen them from the beginning and follows them all the way along.
I was wondering about the standardized patient model. And do you have a standardized patient that has previously had a breach in a professional relationship previously?
You know, we don't, but we'd like to. I think that we do a lot of our standardized patient work with the first and second year medical students, and that specific scenario would probably be a little bit too advanced for them. But I'll be honest, I'd love to get practicing physicians back in to run through our standardized patients, and I think that would be a terrific professionalism scenario.
Thank you.
I currently work in medicine and maternal child health, and I have recently come across a situation where patients ask you really personal questions about yourself because they want to know who you are, but it doesn't always feel appropriate to actually tell the truth because they don't really want to hear what the truth is. I think they're looking for a different answer, like religious belief or, political leanings or things like that. So do you have any savvy tips about ways to maybe deflect it from yourself because it's not about me, it's about them, and just maybe if there ever is an appropriate time to share something personal? I mean, clearly we always have those patients where it's comfortable, but...
You raised some wonderful, wonderful questions that also are worthy of rich discussion because, if you ask physicians, seasoned physicians in practice, do they divulge things about themselves? Of course they do. And they do it with positive intent because there's something to the therapeutic relationship that sometimes divulging some information is actually helpful to the therapeutic interaction that's at hand. I think at any time, however, when there's divulging information that's about you and it's not helpful to the interaction, then I think it's very appropriate, and that's where we like to have the students practice those sorts of words. I'm glad that you're interested in me, but I really find that at this point in time, what we really need to turn our attention is to your needs, your care at this point in time. And in fact, first-year students often will say, I'm asking all these personal questions. It feels only fair that I should divulge all the same personal information back to the patients. I go, no! We have to tell them this isn't a social interaction at a party. This is a professional interaction. The relationship is very different. And so we have those discussions around that. But I think giving them and empowering them to very gently, politely, respectfully, with compassion, tell their patients why, the questions, the personal information that's being asked about them is not germane to the encounter at hand, to the care at hand. Yeah.
I have the impression that the old-time physician, sometimes when he was asked a question, the patient would ask him a question, he would say, don't you worry about that, I'll worry, let me do the worrying, you just go out and be happy or something. Now, I take it, physicians are telling their patients, are leveling a little bit more with their patients as to what their condition is and what their prognosis is. And yet sometimes I have the feeling that the physician, in the back of his mind, is saying, well, I'll answer the question honestly and fully, but somehow or other I won't volunteer any information, even though maybe the problem is that the patient doesn't really know how to ask the question or doesn't know what the appropriate question is to ask. And I was sort of like, what is sort of the current feeling on telling a patient what his situation is?
take that.
Well, I'll start it, but everybody can answer. I think you try and tell the patient everything that patient wants to know. Now, the skill is trying to guess what that is. Sometimes I have explicit conversations before there's bad news, etc. Would you want to know? Sometimes they're saying to you, you know, doc, I just need somebody that's honest with me, that'll tell me what's going on. Other people will say, look, when you get that, don't tell me, tell my daughter I don't want to hear it. Mm-hmm. I am not going to intrude and say, it is now the rule that we tell patients everything, and so you are going to sit there and hear this. But you try and treat them with what you think they want to know. And if you make them part of the process, it's a lot easier. Because if you're trying to guess what it is they want to know, more times than not, you're going to get it wrong. So if you just say, okay, I'm a little stuck here. I'm not sure how much information you want. I'm not sure how much you want to be involved in this and how much you want me to make the decisions for you. Let's talk about that. So that's what I would do.
And I think that's an awesome approach too. And you can read people and how much they want to know and how much they don't want to know, although I think our general bias is to be as upfront and open and honest with people as we can be. But at the same time, people can only stand to hear so much at one given setting. So you kind of play it by ear. And I will say that there are also cultural differences where maybe a person of European descent would want to know everything, but some other culture may not. It may not even be within their cultural mores to tell all the information. So it's really kind of a delicate balance. But I like Linda's approach where it's not so much right or wrong as I frequently ask my patients permission. I'm going to ask you a personal question now. I give you permission to not answer it. It's just part of my job. Because I'm meeting them in the emergency department. I've never met them before. It's all of a sudden I'm asking them questions that are really quite delicate. And I think the same thing applies if you have some bad news. First of all, it's often not all cut black and white when we get initial impression of something. But we do the best that we can given the unpredictability of the situation.
I'm just having a hard time listening to a 2-hour discussion on professionalism without ever a mention of time management and how you deal with those two issues.
Quite honestly, in the first 2 years where we're doing the bulk of our teaching with medical students, we really don't want them to focus so much on time right now. We want them to focus on gaining the skills, hearing the patient's story. If they're so focused on the fact that they have to get everything done in 15 minutes, then we know that we're going to have a student graduating that does not have the breadth, the full complement of skills that we want them to have. Those are things that we talked about, the appropriate development of a student. I think as they go into 3rd year and 4th year, they begin to see in the real world how practicing physicians role model that, how eventually where you might be able to cut corners without cutting quality, where you really make that difference. And you cannot do that with 1st and 2nd year students. You have to give them the time, okay, and to be present with patients to gain the skills. So it's not really a focus for us of time management in the first 2 years, but it is in 3rd and 4th year and beyond. As you know, that's the reality. So we don't talk about billing either, and that's another sad, many other things that I guess we have the good fortune of having some carved out time that we really want them to have the full complement of skill. And we know that as a physician gets seasoned and skilled, they know where to go because they've seen the patterns, they know exactly what they need to do. But it's too premature to be doing that with 1st and 2nd year medical students.
If I can add one more thing to that, there's this model. I taught residents, so it's a little bit different. There's this model called the BATHE model, and it's medical humor. It's not very funny. The regular form that we use is SOAP, for subjective objective assessment plan. So this is bathe with soap. That's the part that's not that funny. But what it is this way of addressing issues, psychosocial issues, within the limits of a 15-minute visit, with the realization that a lot of people won't go there because they feel like they're opening a Pandora's box and, oh my God, what am I going to do when they say something? So it's a very deliberate way of doing this. And what it stands for is, what's bothering you? How's it affecting you? What troubles you most? How are you dealing with it? Well, that must be hard, or a statement of empathy. And it's a really nice thing because it does allow people to know that they can open something and there is an ending to it. And with the how are you dealing with it, it makes it so the patient is not this victim, but a empowered person to deal with something that would make anybody's life hard. So it's a real nice balancer. Does it work all the time? No, but if you keep it in mind, it helps some. The other thing I say is we've got to reorganize. We have to have a rational healthcare system, and we don't have one now. And the amount of time we're supposed to spend with patients limits the quality of care that we can give.
That bathe model works great when you have, as a foundation, a student who knows where to go with it, because they've been the whole distance in terms of a more expanded history taking. So then bathe is terrific because it allows them to go in, open a door, go where they need to go, but they can't go there. They can't learn bathe without learning this other foundation first. Yeah, okay. I think we're out of time. We'll take questions down here for anybody who wants.
A curriculum review at the University of Washington School of Medicine identified the need for more focus on core clinical skills, professionalism, and personalized education. Throughout their education, students take part in a unique program called the Colleges. Within 5 colleges staffed by 30 faculty, small groups of second-year students spend half a day each week at the bedside, working with patients and a faculty mentor. This mentor guides the student for the duration of their education.
One of the ideas that rose to the surface was the idea of linking a mentoring program with a curricular component. And in a way, that's how the colleges sort of came into being.
So the colleges are a way of assigning students right from day one in medical school to a college mentor who will know that student, develop a relationship with that student, and work with that student, particularly in issues of clinical skills, throughout their 4 or 5-year journey in medical school.
To be at the bedside early in our medical school career, particularly in the second year in the college system, really allowed us to have early exposure to what it's like to be around patients in the hospital, and probably more importantly, how to gather information effectively on a patient that's hospitalized.
The college system was great for that. It gave us one person we could always expect to see weekly, someone who could watch our development and could kind of direct us.
Blood pressure was 116/65 and his respirations were 12 to 13 in regular.
Talking to patients, giving feedback about how that was going, and having that early on is going to build habits that they continue with through the rest of their life.
Take care of yourself.
Okay, you too. All right. It's nice to meet you all.
Yes, thank you.
Yeah, good luck in your careers.
Thank you.
One of the important outcomes of our college system will be that our graduates will be
more comfortable and skillful in relating to and caring for their patients. In general, I believe that our college system will produce physicians with more skilled professionalism in their approach to their patients.
Ms. Burke is a 44-year-old female who came in.
I think it's really important to learn how to present a patient with dignity and to learn how to present a patient with enough respect that you would feel completely comfortable to have that patient in the room with you when you were presenting them.
We talked about professionalism. We talked about one of the things I think we're going to talk about today. The college faculty group as a whole has become a very rich learning community itself. It's an incredibly inquisitive, dedicated, highly professional group, very value-driven. Clearly puts patients at the center of the training of medical students and clearly puts medical students at the center of medical education.
Dr. Maestas, as my mentor, she knows our strengths and weaknesses, and I think she also knows our motivations.
I think developing how to do that differential is that will develop throughout your entire career. I mean, I still work at it, you know?
It's valuable. I think it's very valuable to know that Dr. Maestas, as a mentor, is there to just talk with and debrief with, if nothing else.
It's amazing how a small group of 5-6 people in your college group, how they can provide totally different aspects or reflections on a certain situation, and how you can learn from such a small group of people, and in a very non-threatening way, in the presence of one faculty member.
You may insert parts of the history into the physical or parts of the physical. I heard a little bit from both presentations today, and we're just starting, and we'll make you more aware of it as we go on.
I think they get a more comprehensive and more consistent educational program in terms of their tools for clinical medicine. How to do a complete history, how to do a complete physical exam, what is the clinical reasoning involved, and how to do a very good oral case presentation.
And it's pretty hard to practice patient-centered care unless you can remember that the patient sits at the center of the experience. When you go to the bedside, that's exactly where they are.
It was interesting hearing that doctor and them talk about all the different aspects of my disease that nobody talks about. So it was a learning experience from that point of view, yeah.
And a lot of patients have a lot of experience being patients, and so they've sort of seen it all in terms of physicians, and they can pinpoint what's of value to them and almost of universal value to all patients.
That immediacy, that urgency of learning is one of the most motivating things in the world. It's one of the most exciting things in the world.
You know, part of what happens when you take histories is you get a little piece from here and you get a little piece from here, and it all comes together, and it will happen so often to you during your careers that you're telling somebody about a patient, and you walk into the room, you start talking to the patient says something totally different. Doesn't mean that you were wrong, it just means that remembrance is something, it's a dynamic process.
So there is no redness, there isn't, what else is there? It's not tender.
There is nothing more powerful than say, no, let me show you how to do it this way. Reading a book doesn't get that to you.
But you might feel the thrill, put your stethoscope there. Brewery might also sound similar, never as this
If you
loud.
guys want to put your stethoscope on, just don't be bashful, just go ahead and
All right.
do what you got to do.
One of the greatest things is the look in their eye when they first hear the murmur. It's just like a light bulb went off.
Can you hear it?
Yeah, it's quite striking.
And at the end of the year, typically we've got them ready to walk out onto the wards, into a clerkship, and not be that deer in the headlights, but to be ready to go, ready to work, ready to really pitch in and run with it.
To make the kind of commitment that the dean made to fund 30 core faculty to spend as much time and energy and effort revising a curriculum and trying to teach it at the bedside is certainly unique to this institution to the degree that we're trying to do it.
It's been rejuvenating for the faculty. It's rejuvenating for me as dean to see the faculty so engaged in teaching what is basic to medicine.
I think that's great. I will always remember the skills that they helped me to develop and the role they played in my schooling. And I love them all and for their uniqueness and their sincerity and their commitment medicine and their knowledge, probably more so their knowledge. And so I will always sort of remember that, and it makes me happy.
It cements in the student what they came in with: dedication to patient care, dedication to service, and that real compelling desire to be the best they can be.